Nee. Nee, het is Dave die je nu ziet. Hello, hello. Can anyone see me? I hope so. No, we don't see me. No, I don't see myself either. Can you pin me instead of Dave? Maybe that helps. Well, I was going to say welcome to you, and I can do that in any case. Welcome to another day of DevDays, where it's a glorious day here in Amsterdam. And what you can't see is the whole crew with the yellow shirts sitting behind me, ready here to serve you for whenever you need help. I was going to say, and I can still say that yesterday evening we had again of the pub talks, and I was present at the discussion about R5, and we had one on JavaScript, and one was the bell of the standards, and we had well, almost a full house again, 2 times 50, and hey, look at that's me. I hope I'm on now. No. 2 times 50 people and 25 in the Java script one, so that was a pretty good turnout. We are very much surprised by the fact that this works so very well, and we've taken note. We'll try to get some more capacity for next time, but for sure we'll do something. Actually, for me personally, this was the first time that it really felt like a bar talk again, exchanging knowledge with my fellow participants. Since you can't see me, I think it's best if we just switch to the next speaker. And the next speakers are Brian Anderson and John Halamka, and they are going to talk about the role of FHIR in the COVID era. After them, because we'll actually have 3 talks, is John Manning, who's going to talk about the lessons learned creating Power BI dashboards. And then Chris Brancato, a data error nearly killed me despite my HIT career. After these 3 talks, I hope we will have fixed my video connection, and then I'll come back and announce the rest of the things for today. But for now, I'd say I pass the word to John.
Well, great. You know, if the host could start my video, so that way you could see me, because I can't. Here we go. Start my video. There you go. Hey, great to see everybody. Coming you today from the 11th floor of the Mayo Clinic building in Rochester, Minnesota. Can you hear me okay? Can you folks hear me?
Yes, we can, John.
Oh, good, great. Anyway, as I said, coming to you from the 11th floor of the Mayo Clinic building in Rochester, Minnesota, the nerve center of the Mayo Clinic enterprise. And today I wanted to reflect on the importance of FHIR in our COVID era. And I wanted to reflect on 5 eras of COVID. And of course, Brian Anderson will tell you a bit about some of the vaccine credential, or what we will call verifiable clinical information work. So we can go to the next slide. When I say that there are 5 stages of COVID, here's what I mean. So think about March 2020. We suddenly said, oh my, I don't know where this pandemic is going. Isolation is what we need to do. We were in our homes. We were worried about PPE and ventilator supplies, and the question of how in this emerging pandemic were we going to get situational awareness. Now, we did a lot of data collection and instrumentation, but I think during this era, we have to reflect on the following, that EHR systems and ERP systems were not well integrated. So although we were able to understand clinical manifestations using various FHIR approaches and understand things like patient volumes and signs and symptoms and clinical conditions and comorbidities, we really weren't well instrumented to decide, well, if you're seeing a pocket of growth in positive lab tests over here, we better forecast that a week from now, we're going to need to deliver more masks and more ventilators and more gowns to that region. So what we ended up doing in the COVID-19 Healthcare Coalition is use FHIR where we could, but then unfortunately, because we hadn't really thought ahead as a society to API enabling ERP, we had to gather a whole lot of data about supply chain in spreadsheets and manual approaches, and then create visualizations and dashboards to help coordinate some of the supply chain during isolation phase. So maybe the recommendation I would give to all of you is we prepare for the next pandemic, the next major tragedy, disaster. Societal resilience is going to really require we start taking FHIR-based approaches and build these APIs into some of the places we haven't yet, so we have better situational awareness. Well, as we started to then go outside, we had our masks, we understood a little bit about where we could go and how we could get there and social distancing. Then there came a need for testing. Testing started to take many forms. There was the nasal swab that you would get at the lab. Oh, then there started to be various EUAs issued on various other kinds of tests. And we started to see antibody and antigen and molecular tests and portable tests. And of course, the challenge then became, how are you going to start taking all this testing data and start to exchange it in ways that gets into the record so that a patient's testing history is well understood? And FHIR then became a great vehicle for us to start moving data around about who had what test, was it positive, was it negative? And then the systems of record could make interpretations of that testing data and decide, well, were you going back to work or back to school? Could you be allowed to travel and that kind of thing? Now, during this particular testing era, there was also the notion of contact tracing. Now, again, FHIR not specifically used in contact tracing, but it did show us the need for emerging data standards for privacy protecting contact tracing, where we started to exchange things like Bluetooth proximity information using the Google, Apple exposure notification approach. And you saw this a remarkable thing that happened during this phase. Apple, Google, and Microsoft came together on a set of data standards for data exchange to provide a function at national and international scale. So again, many lessons learned for the FHIR movement. As you started to look at what we did there, are there new instrumentations you'll want to do on individual sensors on phones to prepare us for whatever comes next? Well, then we got into the era of cures. We started to ask questions like, do anti-malarial drugs like hydroxychloroquine help us during acute COVID infection? What is the impact of dexamethasone or remdesivir? So we had all these questions. Now, do we have the time to do a randomized clinical trial? We did not. So what did that mean? It means we had to get real world evidence from multiple sites, inpatient and outpatient, and exchange it to understand the impact of some of these emerging therapies. Again, through COVID-19 Healthcare Coalition, we instrumented quite a lot of hospitals and worked with the EHR vendors to create mechanisms of getting that kind of information flowing. And we were able to, within about 2 weeks, determine that hydroxychloroquine didn't actually help. So again, reflecting on that cures era, what would you instrument going forward to make sure that it was just ready to turn on as we started to do real world evidence collection in a pandemic going forward? Well, now we're just coming out of this vaccine era, where of course, as you started to deploy Pfizer, Moderna, Janssen, you wanted to understand some things about side effects. You wanted to be able to connect the data from an EHR to an app so that a patient who might want to go to a concert, a sporting event, international travel, would have the capacity to take that information and be able to say, this is verified, it is signed, it is a FHIR extracted data set that came from a issuer, a provider, a pharmacy, and then I was able to use it for some function that supported my life. So Brian, of course, will give us a fair amount of detail on that effort. Last thing I'll just say, as we approach this new normal, if you just go to the next slide, I want us to think more than just COVID, right? This slide we've tended to use in the Fight Is In Us and COVID-19 Healthcare Coalition to say that if our goal is to work for societal resilience and stability going forward, ask yourself, if you've got a set of goals and you've got a set of sensors and you've got a set of data sources, what do we need to fill in using FHIR so that we can respond with more agility, with more velocity the next time this happens? So you'll see the middle of the triangle is left for you to fill in as we keep our eyes on the lessons learned the past year and look forward to the years ahead. So let me turn it over to Brian to talk more about verifiable clinical information using FHIR.
Thanks so much, John. And if you could advance to the next slide. So as John really teed up nicely here, the era of this new normal, and particularly coming out into the reopening of our society and our economies, has created a very interesting opportunity to leverage FHIR to empower individuals to be able to share trustworthy, verifiable records of their clinical information, and in this case, their vaccination credentials. And so what I wanted to dive a little bit more into is one of those stages, that new normal and vaccinations that John described earlier, and share a little bit with you about how VCI started and a little bit more about smart health cards. So next slide, please. So back in September of last year, a number of large corporations in the private sector came together asking that question that John ended his presentation on. How do we help create a more resilient society and facilitate the rapid and safe reopening that we are all looking forward to? Now, recall in September, we weren't even yet through the winter, but vaccinations were right on the horizon. There was conversation about EUAs and the hope and the promise of what vaccines would offer. And so when we began asking that question, many of us believed that it was only in doing something together as a coalition of the willing, that we could align around a common approach, a common standard, to enable individuals to participate, again, in a safe way as part of that reopening of society. And so you can see some of the logos here of many of the organizations that later in January of this year, when we formally launched VCI, came together and announced our mission and our vision. The organization of this nascent coalition immediately, as I'm sure many of you have seen in the headlines, got a lot of news attention. The ideas of vaccine passports and vaccination records and show me your papers is a hot button topic for many people. But nonetheless, it was something that attracted a lot of interest in the technology sector and in the public sector in terms of how we can use these digital health tools that FHIR enables, that Smart on FHIR enables, to empower individuals. And the organization, the coalition, quickly grew to over 475 plus companies. And when I was thinking back about how coalitions in FHIR have started, of course, we're all familiar with the Argonauts and more recently FHIR accelerators. And when I think about what VCI has done and how this group of companies came together, leading engineers, many of you watching now, it came together with that same concept of let's identify a technology standard that we can rapidly develop a common standard and framework approach and implementation around, and then work with the implementers to iterate to improve on a very specific, narrowly scoped use case to demonstrate that we can deliver, that we can develop traction on in the adoption of this standard. And that's really what we started here and moved out on. Next slide. And so you can see up here on our screen, just some of the key elements of what VCI's charter has been about. And many of these points are very similar to the coalitions that many of you have been part of in HL7 and in the FHIR space or in any of the accelerators that are represented here during DevDays. It's about empowering individuals to be able to tell their own story in a verifiable, trustworthy way of their own clinical information. It's about, of course, harmonizing the standard and the specifications and the implementation guides that we have within VCI to support, and this is the use case that we focused on, issuers. And I'll get to more about what that is specifically in a moment, but that was the use case, is focusing on issuers of these verifiable credentials initially. And essentially, at the end of the day, the end user, the individual, being empowered to be able to use those verifiable credentials, as I said in the beginning, to tell their own story for whatever purpose they want with their consent to share it with whomever they want. And of course, this is the bigger picture of VCI, right? It's not just vaccination credentials, it's verifiable clinical information. And that is where we are all moving within the digital health ecosystem today, is the empowerment of individuals as consumers, as owners of their own data, the ability to share that data in a provenance-enabled, verifiable, trustworthy way, is an incredible watershed moment where what we've experienced now within VCI is the adoption of the standard, such that many of you later this summer will have the ability to download a copy of your own verifiable vaccination credential. This will be a specification that has, very similar to how Argonauts rapidly drove adoption of a core set of specifications and standards amongst the EHR vendors, we've taken a very similar approach within VCI, such that now later this summer, again, many of us, because of that adoption in some core vendor partners and health systems, will have the ability to use those verifiable credentials as you see fit. Next slide. And so, why is an interoperable open source standard so important? Why does it matter? A couple of things. So again, lots of press around different kinds of solutions, different kinds of ways of showing verifiable credentials. And what we were most concerned about within VCI was ensuring that we were not disenfranchising anyone in our society from being able to participate in this societal reopening, in being able to demonstrate in a verifiable, trustworthy way that they have in fact gotten a vaccination as the first use case, right? And so where there would be proprietary locked in technology that you might have to pay for as an end user, we wanted to nip that one in the bud, frankly. We wanted to create so much momentum, so much adoption around a core set of partners that would not be something that we have to worry about. And I'm happy to share that I believe that's the case. The vast majority of the technology partners certainly in the United States, and it is something that is going international, have adopted smart health cards as the open source specification, such that these will be interoperable and freely available, so that the issuing entities, be them health systems or be them state registries or others, have the ability to make these available to you for download, for printing on a paper and a machine readable QR code, or a digital one on your phone. It was that desire to align around a standard that enabled that what was so important. And again, lots of challenges here in terms of navigating the politics and the sensitivities in the federal landscape, but I'm very proud to share that from a private sector, those organizations that have participated in VCI, many of the software engineers here watching today have been the body that has created the movement in the private sector that has enabled this kind of widely adopted standard now for verifiable credentials. Next slide. And so smart health cards themselves create a framework. And that framework is issuers, verifiers, people, and the technology vendors that they are part of. And so if you could advance to the next slide, I'm sorry, it might show, go back one more slide, I'm sorry. And so it's not showing up here on this, but the issuer community is the community of individuals that have the ability to issue these credentials. They're the ones that have records of vaccination. So these are the sites that actually put the jabs in the arms. These are individuals at health systems at community health workers that might be at mass vaccination sites. The verifiers, these are individuals or entities that are destinations. So they could be restaurants, they could be amusement parks, they could be venues for mass gathering. They are the ones that consume the verifiable credential at the destination level. And then there are the technology vendors. Those are, of course, the entities, the stakeholders that actually make all this happen at a technology layer. And of course, central to all of this are individuals. These are the holders of the credentials, the ones who own the verifiable record of their health, in this case, their vaccination status, who with their consent get to decide who they want to share that with and in what context. Next slide. And so bringing that all together, what FHIR and the Smart on FHIR app ecosystem has enabled here is a relationship between, and then moving left from right here, the issuers on one side, the verifiers and the destination sites on the other, to create essentially a trust framework where verifiers via PKI method can ensure that the credential that they are consuming from an individual has not been tampered with, is trustworthy, and is accurate. They can also layer on different kinds of business logic. That the individual get 2 shots of the appropriate vaccination or 1 shot in the appropriate time frame. Are they safe to enter or safe to travel, represented there by that green and red dot? And so what FHIR has really done here is enabled a framework of trust that allows for individuals to participate with verifiers and issuers in a consent-driven manner to share their data, to share their health data, the record of their health vaccination status, in such a way that is not going to, again, with smart health cards, not going to leave behind people that don't have smartphones. And so that, again, was a really important equity that we wanted to consider within VCI, is ensuring that individuals that aren't as technologically adept or might not have a smart device can participate in this process as well. Next slide. And so if you're interested in learning more about the whole effort and just the incredible community, many of you, again, probably have participated in it. It's a very active FHIR channel. The whole data model is in front of HL7 for balloting. We have several channels on Zulip that are working actively to mature this. But again, the initial use cases on the issuance of these credentials. And soon we'll be pivoting that to focusing and coordinating with other use cases. They could be outside of vaccinations. We're thinking about rapid diagnostic tests, also looking to offer more support to verifiers and other use cases. Next slide. So this is an example of what that card looks like. Again, excited to report that later this summer, many of us will be able to download these and have access to these. But again, this is an example of a community coming together of what FHIR has been able to enable in an incredibly rapid time, such that, you know, tens, if not hundreds of millions of individuals will have the ability to download a card just like this within the next few months, because of what started with 12 companies, rapidly grew to over 500. And, you know, here we are today, ready to participate in this reopening by being able to leverage these kinds of records at an individual's choice. Next slide. The last thing I wanted to share was the other layer that smart health cards and FHIR essentially enables here is these derivative passes or health passes that many organizations, many of you are probably aware of. These are Common Pass, Clear, IATA's Travel Pass, Good Health Pass. These are derivative passes that consume smart health cards that offer a variety of different services. Remember, I mentioned at the beginning the success of VCI in focusing on a very narrow use case of FHIR-enabled open source standard for verifiable credentials did not focus on identity management, did not focus on the business logic that determines if one is safe to enter into an area. These are things that were enabled as part of the broader digital health ecosystem that these organizations have stepped into and have offered these kinds of health passes that are consuming smart health cards. And then with that additional layer of identity proofing or business logic for vaccination status, are able to offer to destinations. And so we're really excited to see this kind of community begin to develop within the verifiable clinical information space. Next slide. And so that's it. We're really excited. It's been a real pleasure to partner with many of you, certainly with Dr. Halamka. Thank you so much for your leadership in this space. If you're interested in learning more about VCI, you can check out our links here. We have the technical details and implementation guides there all up on the screen. But with that, I think I will call it a wrap and pass it off to Mr. Manning. You're up next, sir.
Thank you so much. If you can stop sharing your screen so I can share mine while we get this up and running. I have to say it is an absolute honor and a pleasure to have my first FHIR DevDays talk as a keynote. And I look forward to joining you all at future talks in person at Pub Talks and with interest over Pink Socks. It's also a clear honor to be up as the following speaker after Dr. Halamka. A bit about me. So I'm John Manning. I am a physician by training. I hail at Atrium Health in Charlotte, North Carolina. Specifically, I work at their flagship hospital, Carolinas Medical Center, in the Department of Emergency Medicine. My roles are assistant professor and director of clinical informatics within that department. And in large part from the FHIR perspective, I do consider myself to be more on the implementer side. I think there's a lot more that I can learn from the FHIR community as a whole. From the developer side, I am also a Google developer expert in Dart and Flutter, of which there's 70 in the world and only one in healthcare right now. Through this and through Flutter is where we've created Firefly packages, which have been discussed by Gray Falconberry, and Liz will talk about some things that we've connected through FHIR. But from my perspective today, we're going to look at the concept of having data already available to you. And then what lessons can you learn as you're looking at this from the perspective of building your own story? Once those data elements are now available, let's take a look at the individual perspective as well as the complexities. And really, I'm going to cover three things today. The first is the question of, well, what are my blank? The second is one specific demo that answers that question and covering elements of what we've learned through data modeling, data scrubbing, and applying something defined as institutional memory. And then we'll end kind of recapping some of those concepts and whatever lessons learned that we have that are available. From henceforth, if you want the slides, please feel free. This is my Twitter handle as well. And my interest through all this comes from usability. 10 years ago, I had the pleasure of doing some work and meeting Dr. Ben Schneiderman from the University of Maryland's Human-Computer Interaction Lab. And his article that's now 25 years old, which is our information-seeking mantra, is something that I built through the last decade's worth of visualizations and dashboards and things that I built, which was overview first, zoom, rank, and filter, and then details on demand. And in his article, he repeated it 10 times, saying every single one of these was a lesson that I learned that I had to come back to this mantra. And my spin on this is you need a visualization that is interactive, that allows the end user to perform some form of analysis so that they can get insights from those data. And so when I had joined at Atrium Health after an informatics fellowship, the first question to me was, what are my metrics? And it could be efficiency or quality or outcome. And following that lens of top and further down into different layers of complexity, I like the analogy of a car. So you think about it, if you're purchasing a car, you will have maximum speed that the car can go and efficiency metrics of how many miles or kilometers per gallon will you get. And if you're looking at the published data of highway versus city, that's very different than when you actually have the car and you're filling the tank each month or whenever it's time and just basing, all right, well, what was mine for this cycle? And some cars also have on the speedometer a gauge just below that will tell you your estimated efficiency if you keep using fuel at this rate. So if you hit the gas, the efficiency goes down. If you hit the brake, the efficiency comes up. And really that final element, I think, is really what we were trying to build with these dashboards, because the high level stuff is very different than when you get things down into the context. And in 15 years as a medical student, as a scribe on paper, when we had transitioned to electronic, resident fellow, et cetera, I've seen about 20 different health systems up and down the East Coast and the Midwest. And each emergency department is different, and rightfully so. And as you're looking at this, and I've worked at all of these institutions, as a fellow, I was in a freestanding emergency department, critical access hospital, where you have only 4 rooms and 15,000 visits per year. So you have to be creative with your rooms. Versus where I trained, we went to a community emergency department, and there's only 1 attending on shift at any given time. Compared to where I work now, where we have anywhere from 3 to 6 attendings and multiple treatment areas, and are creative in the way that we do collaborative patient care and make use of the space that we have available to us. And to bring you all the way in, so at Atrium Health, they have invested $1 billion in capital investments to build a brand new tower. So in the next 5 years, we're going to have a wonderful new emergency department. Right now, where I work, this is what I see on shift. So put on your hat, put on your mask, get your goggles. And if you are caring for adults, what you will see, chances are you're going to see them in one of these 3 treatment areas. The walking healthy are in AEC, or ambulatory emergency care. The very complex patients are in diagnostics, or DIAG, and the sick patients and trauma patients are in major. And we have a means for internal capacity if we're out of rooms, so that patients can wait while they're getting their workup, as well as surge capacity, where we have a permanent tent that was built around the COVID in response to the COVID pandemic, and similar structures for the pediatric side. And if you think about it from the patient's perspective, and the question is, all right, well, does the efficiency in major reflect that in DIAG and AEC? And every one of us on shift is that absolutely not. This is extremely different. It's almost like working in a whole different location. And so if you have your patient and they just go to one spot and they leave, they get admitted or discharged, that's an easy workflow. But think about the nuance and the complexities. It's a busy day, and instead of showing up through intake, they actually go to AEC, where they have an intake provider evaluate them and get some stuff started while they get worked up and are waiting in the VCA, the vertical care area. And then when they get a room, be it in DIAG or major, well, now they're really sick. Maybe something happened. Maybe there was more to the story. And now they get upgraded to major for resuscitative efforts. Think about that from a data perspective. How do you track that? Because when you're building your visualizations, you really want to compare apples with apples and oranges with oranges. And so this is what we built. We used Power BI, which is an excellent dashboarding tool available through Microsoft. You can integrate it into Microsoft Teams so that all of our providers can see this. There's also a web-enabled version and a desktop version. And if you've not used the desktop version before, this is where you build your reports. This is where you look through your data, and this is where you build your models. And you can make some pretty powerful transformations there. So our dashboard, I'm going to give a couple of caveats. First off, our efficiency, I consider true efficiency when we are no longer using pajama time of documenting and doing work at home. And this is not a FHIR-enabled dashboard that I'm showing, but if you have access of the data through FHIR, you can certainly apply these same lessons learned. And just like I wouldn't publish all of my patients' information available on a recorded video for everybody to see, I'm providing some respect and privacy to my fellow faculty. And so all of the numbers that say 37 are not real numbers, but the actual real numbers are hidden below. And so if you look at this, you can actually go through from the high level perspective. And here I'm going to actually click on a person's name. And from an individual provider, you can see the month, you can see the year, and you can see all of the locations where they worked. And then all of these efficiency metrics built in, and will give you what the breakdown is based on their location. And these elements are also available for the faculty and the pediatric faculty and the fellows. And each person has their own unique name, which is available to them so that they can see their own metrics, as well as comparing that to their peers. And the idea through all of this is so that you can get a good breakdown of where you are as a whole, in the locations where you worked most frequently over the last 1 or 2 months, et cetera, and compare that to others. And for those who are interested about the pediatric side, there are some peds and adult trained physicians that are there. So some insights from this. First is the complex relational databases that are available within Power BI, I think is excellent. And when you look at our data model, also with some elements that have been renamed, we really are pulling from 3 different locations. One is through our billing environment, one is through our clinical environment, and one is through our shift environment, which isn't even clinical data. This is our scheduling software. And then we're applying an element of institutional memory so that if somebody was started as a resident, turns into a fellow, they graduate, they're working for a year, and then they join on as core faculty. Well, you're not going to compare their resident data to the faculty. You really need to compare it at the same time. And you can do some elements of really powerful work through the transformed data elements within Power BI. Good example is, so you can either do this as a point and click or through their language, which is Power Query M. But a good example is if you want data that are like this, where you get users, shift, date, and the time and start times, but your data aren't that cleanly defined. You get a user that's a random row that you don't know exactly where that's going to be, or a date that is a string that is also connected to the day of the week, or your time slots also as visualizations. Then you can take the step approach through the point and click interface, or you can use the code itself, and please comment your work so that you do this once. And in our setting, this one single element took us 6 hours. And then we never had to do it again. And I think there's really a lot of power in that. And in a similar way of considering that memory, where you go from resident to fellow to attending, how can you do this in a manner that is useful over time? And just in a similar way, you create another table that just has your, when you were at X or Y role, and then you do the equivalent of a SQL join within the transform data section of Power BI. So in summary, we've implemented this as a somewhat recent event within our department, and it's been extremely well reviewed and received. And the immediate next question is, this is great. Can we get this for another operational metric or quality metric? Or can we get this for additional providers that are here? And our system is transitioning from one electronic vendor to the other on the clinical side. And we can easily swap those elements on a modular format, which I think is really useful without changing the visualization as a whole. If you take the time to figure out how to automate your data scrubbing, and Power BI gives a really good means to do that, it will save you a lot of time in the down run and in the long haul. And those elements of institutional memory, especially when you're looking at people over time, I think is really, really important if you need that granular level of detail. And I'm happy to provide later today other tricks and lessons learned, including connecting a patient to a provider's clinical shift. But I think for the time being, this is really what I wanted to cover. I want to thank you all for this wonderful opportunity. And with that said, I'm going to pass it over to Dave de Brancato, who is more commonly referred to on the internet as ePatient Dave. Thank you all so much.
Wow, wow, wow. John, I want one of those dashboards that has metrics for did the patient feel like they were taken care of. That's what we got to find some FHIR resources for that. So, ladies and gentlemen, let's see. Start my video. I think I already did. Welcome to the 4th DevDays patient track. Some of you have been with us from the beginning, but for those who weren't, it was 2 years ago at DevDays in Seattle, where some of the top people in HL7 agreed that FHIR exists to serve patient needs. And since then, we have been making a point of having actual patients speak. Could you, next slide, please? The patient empowerment work group was started shortly after that. Here's our homepage on Confluence, and look at the projects we already have going in the bottom left. And importantly here, the first speaker today Chris Brancato will speak about the issue of errors in the data, including one that nearly killed him despite his career in health IT. And tomorrow's speaker, Katie McCurdy, will be speaking about patient contributed data in a way that will blow your mind. Her point is, you may have my data, but you don't have my story. We're building a new vision here. And the last slide, please. So this is what we're going to be talking about. Last slide. Chris's talk, a data error nearly killed me despite my health IT career. Please be aware, this project we're working on to define the protocol and resources for getting errors corrected, every one of those errors is a potential death bomb. And with that, I'll hand it to Chris.
Thanks, Dave. It's great to talk to you all today. First of all, I want to say that this is a very personal story. I wear the scars of what happened and every day. And people ask me all the time, you know, what's that tracheotomy scar for? And what's this scar for? And what's the 19-inch scar you have down your back all about? So what's really hard about this for me is I'm going to share with you some impact on my family. And so this was a couple years ago. I have had 7 spinal cord surgeries since then. And hopefully I just had my last one a few months ago. Next slide, please. So what I do, I am an informatics guy, a nerd, clinician by training. I've worked working with this all the way back before HITSP. And I know some of you don't know what that means. So I will say in the, as I'm going through my medical event, so many people that I have met through HL7 offered words of support and assistance. I can't begin to thank you all. So I'm going to take that opportunity right now to do that. Thank you. Next slide, please. All right, so the story starts this way. I was having progressive severe neck and shoulder pain. It got to the point where I could barely move my arm. I certainly couldn't feel it. My left foot started to drop. My wife finally convinced me to go see a doctor. I had assumed that I had separated my shoulder again, like I did playing ice hockey in college. So I figured, you know, time crept up with me. I'm going to have to get it revised. Well, it turns out that that wasn't the case. I went to see a doctor. And he said to me immediately, it's not your shoulder, it's your neck. And so off we go, and I get scans and x-rays and whatnot. You're seeing one of them right there. Let me take a quick moment to navigate this. This is my tongue at the bottom. You can see the spinal cord there. It's patent for the most part, meaning it's not impinged at all. And then as you go to the right of that, you can see the discs, my spinal discs that have protruded through the spinal cord. In all effect, I had been in a car accident and ultimately ended up with the doctor mandating that I could not drive home. So less than 24 hours later, my wife, I'm getting worse. My wife is taking me to the emergency room. By the time she rolls up, I am unconscious and I'm paralyzed from the neck down. Now the fun begins. So the treatment plan was, we're going to have to decompress, get these things off his spinal cord. Next, please. So, after 8 hours of surgery, with not one, but 3 neurosurgeons, all of whom had said they have never seen anything like this. So I wake up a little bit post-operatively, and I say to the nurse, I'm bleeding. And of course, she made me describe it to her. Doctor shows up, right back to the OR. And as I open me up, the stitches break and I start to bleed profusely. I was awake when they performed the tracheotomy to save my life. And that's because all the blood had collected in my throat, in the tissue around my throat, and essentially choking me. That was my first cardiac arrest. 2 days later, the same thing happens, except now I have a tracheotomy. And I wake up and I mouth to my sister that I'm dying this time. At the bedside, the surgeon expands a 2-inch incision to the 8 inches that you see in front of my family. The good news was my family is all medical people. It's kind of our profession, family profession. I am awake for this one too. Massive blood loss leads to my second cardiac arrest. Fortunately, they didn't see that. It was in the OR. And so they begin to resuscitate me again. After I'm stable and back in the ICU, I spent almost a full month unconscious in the intensive care unit. They put me in a medical coma just to make sure that they could kind of sort things out a little bit. After this all started to happen, things didn't add up. My wife, my family wanted to see the chart. And I can tell you from the onset, I have not sued anyone. That was a negative, but I didn't sue anybody. And at the scheme of things, first of all, things happen. But second of all, it would have taken all the voice that I would lend to this to keep it from happening to someone else. But the hospital responded immediately. And I can tell you that was the most important thing to me was things happened. Don't try to hide it. Bring the patient into this conversation, or his advocate as it is, and then let's find out what happened. Next slide, please. So Eureka, I was in and out of consciousness, so I was able to somewhat be coherent and tell my wife, where they should look. I think we jumped a slide. Did we jump a slide? Can you go back one? There we go. Yeah, that's the one. So the picture you see there is my neck in its present situation. There's a spinal cage there. There are rods and posts. Essentially, they have reconstructed my neck. Some key things happened as this progressed. First of all, my wife could not recall all of the medications I was on. And that's not uncommon. People who are well-educated and attuned to a patient just vapor lock. Happens all the time. So my wife went to the pharmacy, and I won't identify the pharmacy, but the pharmacy refused to release to her my active medication list because of HIPAA. It would have taken weeks to do that. Anyway, what we found was the primary care doc's CCD that was imported in the hospital system did not contain the medication I was on. In this case, it was Excitlopram, which is an SSRI. And just so you know that SSRIs frequently introduce bleeding disorders just by nature of a drug-drug interaction. So she collected all my meds, gave it to the doctor, and the doctor was like, what am I going to do with all this? I don't know what he's taking. So next slide, please. So this is where they found that the citalopram was in the CCD. However, it didn't appear in the hospital record when it was imported. Still don't know what happened there, but we knew that through the breadcrumb trail that this is the introduction of the problem. However, what we did find is the local HIE that the hospital participated in, that summary record, that CCD did have the drug allergy. And so I think the lesson here is once they found it, they could very easily correct it, and I stabilized very quickly. Next slide. So to sum this all up, because we're up against time, having a great advocate is critical. So let me go back to this picture. This picture was taken 2 days after the neurosurgeon told my wife that I would never walk again. As I got out of bed for the first time, I wanted to show my appreciation to him. What we're due here is not about interoperability per se. It's about predictability of the data, which goes well beyond the ability to do a machine-to-machine data transfer. It's context, it's discovery, it is being able to edit the record when the records aren't right back to the sources of that data. What I love about HL7, and I have been a member of HL7 for 15 years, the patients and clinicians get together, they count on us to get this right. It's tough work. I've been at it by 20 years. FHIR is a potential path to do that. I am totally convinced of that. Never forget the patient in what we do. Remember these scars, okay? So as an added benefit, my family has a deep appreciation of what I do and what you do. And now they want me to fix their EHRs right now. So with that, thank you. Dave, back to you, sir.
So moderators, who's next? Are we finished with the session?
Yeah, no, it's me. If I'm live, I hope. Yes, look, it works again. Well, that's great. Thank you, Chris, for this story. Man, I'm silent. I don't know what to say about that. That's impressive. Luckily, I must say that we had a little bit of a problem in the beginning, because this way I just missed all the slides, and so we had a little bit of time to go over time and let you finish your wonderful story. So I've only got one thing really important left to say, but that's for the rest of the program today, is that at the end of today we'll have the usual wrap up, but after that. We don't have the pub talks this time around, but we will have a social event, which is a singer who will perform for us at 5:15, and he's called Dave Rudolph, and the title of his program is The British Re-Invasion. So no pub talk debates tonight, but some kind of singer sing-along. I hope you're going to enjoy the rest of your day, and see you at the next session. Bye-bye.